Today we are talking about radioprotection of critical structures and radiation for pancreas and liver cancer. And notice that the title of this slide is really about, being safe when you're trying to do this treatment. As I said, liver and pancreas SBRT is very tricky, but it can afford benefits to these patients who are often very sick and have limited treatment options. These slides are from Dr. Sastry Vidam, who borrowed some slides from Dr. Gabriel Sawakuchi at MD Anderson. So beginning with pancreatic cancer, the oncologists probably all know this, but rarely does radiation cure pancreatic cancer. Radiation is just part of the treatment. And really to get the best outcomes of pancreatic cancer, you need to have surgery to remove it. And the holy grail, what everyone is trying to do is they're trying to remove it with negative margins, meaning after they take out the specimen, they don't see any more sign of tumor. And only a small percentage of pancreatic cancer can be removed with a good chance of negative margins in the upfront setting. Okay, only 10 to 15% on this slide. And in some cases, we can't resect it because the tumor is involving important vessels. The SMV in yellow, this stands for superior mesenteric vein. SMA, the superior mesenteric artery. And here, this gray you can see is the tumor, and the oncologist is looking at this, and they're seeing the tumor is wrapped around these vessels. So if someone tried to cut the tumor out, they would cut those vessels, and the patient would bleed to death and die. So this is considered unresectable, and a fair amount of these pancreatic cancers are unresectable. And in some cases, not shown on the slide, the tumor is next to some of it, but not all of it. And in those cases, it's considered borderline resectable. This is one place where radiation could help shrink the tumor away from the vessel so that then the surgeon can come in and safely do the surgery. Okay? And then, unfortunately, a lot of times pancreatic cancer presents metastatic. And at this point, you can't cure it. Chemotherapy is going to be the main treatment. So radiation may help for palliation in certain spots where there's pains. And we do have nerves around here, the celiac plexus. It's very, very painful if the tumor is touching that. So sometimes radiation will be used for that. But in this case, I would say that we're considering radiation in the setting where we need radiation because we can't do surgery. And maybe radiation can help the patient live a little bit longer. Or maybe radiation can help us shrink the tumor so much that the surgeon can then take it out and we can pray for cure. So as I mentioned, it can only be cured if the primary tumor is removed surgically. And then what do you do when you have a treatment-resistant cancer that cannot be removed surgically? And this is what I'm saying. This is the context of SBRT for pancreas. So the tumor requires a high dose. And then the duodenum is part of our bowel. This is probably the hardest OAR to protect when you're doing liver pancreas SBRT. And you can see it's so unfair. It's just wrapped around exactly where the tumor is. So we need to have a very sharp dose fall off in order to do this treatment effectively and safely. This is an axial view. You can see the tumor is circled in red. We can see this is the duodenum in orange. This is other parts of the bowel. And then this is the liver. Amongst these structures, the duodenum and the small bowel are going to be the most sensitive. The liver has a capacity to repair itself. Sorry if this is too basic, but for the liver, if a small part of it gets a high dose, that's okay. Our main dose limitations with liver is if there's a large part of the liver getting a large average dose. So mean dose is usually what limits us for liver, not max dose. So look at how they planned this. They created a sharp dose fall off here so that the dose is getting lower very quickly as it's close to the duodenum. And as a consequence, the dose has to spill in other directions more. Okay, they should probably also contour the kidney. The kidney is another structure, but it's more of the mean dose that matters because it's a parallel organ, or it's a parallel organ. Okay, so this is a common dose to give for pancreas SBRT, 8 gray times 5 fractions for 40 gray total. And you want to limit the volume receiving 35 gray to less than 1 centimeter in your duodenum and your small bowel. And another constraint you'll see is a dose max of 30 gray. So somewhere in the 30 to 35 range, you start to get nervous if your dose is higher than that in the duodenum or small bowel. Any questions? Okay, so has a good comment. The tubules in the kidneys are the serial organ. That's true, and I'm not exactly sure, if there's more specific contouring for the specific tubules, but I would follow the TG 101 constraints for kidneys. Okay, yeah, we'll get into contouring the volumes. Thanks, Lynn. So I feel like I've just said this so many times. But there are sensitive structures close to pancreas tumors. These are just some other pictures. Does anyone know what this white thing is? This white thing that we see here. Feel free to type in the chat if you know.
Stent, yeah.
Yes, that's right, Jacindra. The stent. So, metal shows up as dense on the CT scan, similar to bone.
Looks like Leif had a question before that, though. He's asking about your volume of GTV, CTV, and PTV.
Yeah. So we'll get to that. It's coming up. So this is a stent. Sometimes it's helpful to know where the tumor is in relation to the stent, but remember that the stent isn't attached to the body. It's just inserted in a place, and then the stent can slip and it can move around over time. So if someone had a stent placed a month ago and then they got a CT scan, the tumor was in a certain position in relation to the stent at that time. Now, a month later, you do your CT simulation and you're looking, and maybe the stent has moved. So now the tumor is in a different position relative to the stent. You can't just line it up according to the stent and then think of it, it's perfect. Okay, so for the pancreas, other things you might consider lining up to, checking, okay, where was the tumor in relation to X structure? You could consider the vessels coming off of the abdominal aorta. So your celiac artery or your superior mesenteric artery. Those are good sort of landmarks to consider to make sure you're in the right plane. Okay, so how do you protect critical structures in the pancreas SBRT setting or in the liver SBRT setting? Because liver SBRT also has similar structures around it. With simulation, you need to use IV contrast, or else the liver is just going to look like a gray blob. Everything looks the same in the liver if you don't use contrast. There are different phases. There's the portal and the venous phase for liver. And then if you can, and we haven't talked too much about this in this course, but breath hold is definitely preferred if the patient can tolerate it compared to 4D CT. I wouldn't start with breath hold if you haven't used breath hold for other disease sites. Okay, get comfortable learning how to use breath hold for lung before you try using breath hold for liver. Because if you do breath hold wrong, you could be missing 100% of the tumor every single treatment. So breath hold, if you do it right, it can be great. It makes contouring easy. It makes the volume for your B and your PTV much lower. With breath hold, essentially everything is static, so you don't have an ITV, and instead you just have a PTV. And with a smaller volume, you have less toxicity. But like I said, if you do breath hold wrong, you got confused when you were registering the images, which is a very easy mistake to make, then you will just always be wrong.
Hassan has a good question. He's asking, what about abdominal compression?
Yeah, I think abdominal compression can be helpful. You'll see variation in practice, but if a patient can tolerate it and it reduces the motion and you feel comfortable that when I use abdominal compression, I get a consistent reproducible effect, I trust this restricted motion, then you can use it. But you do need to always be mindful, even when you're not using abdominal compression, that like, is a patient breathing the same way that they were breathing when I did the CT simulation?
I think is circling back to the IV contrast part. You said there are a couple of phases, right? So she's asking which one would be the better for simulation.
Yeah, it can depend on the tumor type. So I think that's a good question to read into further, but read into which phases are used for hepatocellular carcinoma, which phases are used for metastases in liver. So it's a good question to explore. I think you'll learn a lot. SOHA, I think the abdominal compression synchronizes the breath cycle, but it does not breath hold. Yes, that's a great point, Soha. So abdominal compression, some sort of belt around the tummy is not the same thing as a breath hold. Okay, because even if it's a tight belt, there's still going to be breathing and there's still going to be motion. Breath hold can be done in two ways. I think the classic way we think of breath hold is that we breathe in and then we hold it. And then we breathe out and then we breathe in again and we hold it. And while we're holding our breath is when the treatment is happening. Now, when we do breath hold, that's a inspiration breath hold. The diaphragm is going down, and then we do the treatment. There's also expiration breath hold. And some say that expiration breath hold is better when you're treating GI cancers because of the way the movement is. It actually, instead of bringing the tumor, so inspiration breath hold might bring the tumor a little bit closer to your guts, whereas the expiration breath hold might bring the tumor further away from your guts. Expiration breath hold is you breathe out, and then you hold it. And then you breathe in, and then you breathe out again. And then you hold it. If you try doing expiration breath hold, you can test it yourself. It's hard to do. And so if you're going to tell your patient to do expiration breath hold, have them practice. Like tell them, I want you to go home and for the next week, just every day practice holding your breath in the expiration phase. And then when they come back a week later for the simulation, they're going to be so much better at it and they'll actually be able to do it. So this is something you can tell your patients to practice. Then we have treatment planning, which we're going to get into, and then treatment delivery and MD Anderson, they use CT on Rails. We don't use this at UCSF, so I don't have as much experience to share about it. During the presentation, this was a confusing topic, and I wanted to go into a little bit more depth to explain it. So on the previous slide, we saw this diagram, and this shows the different contrast intensity, or how bright things look on the liver during the different phases of circulation. And starting at time equals 0, the IV contrast has not had time yet to begin circulating through. So essentially, this is without contrast. The liver all looks gray and pretty similar. So even if there was a lesion, we may not see it because it'll look the same as the rest of the liver. We inject IV contrast, and now it begins to flow through our arteries. So the first phase is the arterial phase, and we can see that, as expected, the aorta, or the largest artery in the body, fills with the IV contrast during the arterial phase. And we see that the liver gets a little bit brighter, and we see that, in this case, hepatocellular carcinoma gets very bright. So you can see HCC well on the arterial phase. This arrow here is showing the difference in brightness. So during this arterial phase, the liver is getting brighter here in the red curve, but the HCC is getting really bright. So that's what you can see here, where this hexagon represents the HCC. Then, as time progresses, we are sort of ending the arterial phase and getting towards the venous phase. You can see that the liver is still holding on to some of that brightness, but the HCC is already starting to get darker. Noticed here, it's a little darker. Now you can't see the difference as well. And then we get into the portal venous phase. So remember, the liver has a dual blood supply. The first part is the arterial blood supply through the hepatic arteries. And then the second part is through the portal vein, where all of the deoxygenated blood from the GI tract is now flowing into the liver through the portal vein. And we can see during this portal venous phase that the liver is still holding on to some of the brightness it got from the arterial phase. And the HCC is now even darker. Here, it's darker. So just reviewing that, no contrast. Now we're in the arterial phase and things are brighter. We can see a big difference between the HCC and the liver. Now we're in between the arterial and the venous phase. HCC is not as easy to distinguish. And then we get into the portal venous phase. And now the HCC is much darker than the liver. So once again, we actually can see a big difference. So in conclusion, for hepatocellular carcinoma, you want to acquire both the hepatic arterial phase and the portal venous phases when you do your CT simulation in order to have the best options to contour liver HCC. And whoever is doing the contouring can use CT scans taken at each of these phases to make sure that they're covering all components of the hepatocellular carcinoma. Next, let's see how the contrast dynamics look for liver metastases. So once again, when time equals 0, essentially the contrast has not begun circulating yet. So this is the liver looking all the same, all of it is gray, and it'd be very hard to even see or notice where the liver metastases are. And then we get into the arterial phase. The liver's getting a little brighter, and the liver metastases are getting a little brighter as well. But you can see it's still hard to tell the difference too much between this. Both got brighter by a pretty similar amount. Now we move on. We're in between the hepatic arterial phase and the venous phase. And we can see that at this point, the liver metastases is starting to get darker, whereas the liver is staying bright. And then when we get to the portal venous phase, now look at this difference. The liver metastases in this blue line is dark, and the liver is still relatively bright. And looking at the image, you can now distinguish the metastases compared to the liver. So in this image, the liver metastases are clearly darker than the liver, and you can see it. So just again, time equals 0, without any contrast, everything looks gray, and it all looks the same. You can't see the metastases. You get into the arterial phase, the liver gets brighter, metastases also get brighter. It's still hard to tell the difference because they both got bright. Then in between the arterial and the venous phase, the metastases are starting to get a little darker, and by the time you reach the portal venous phase, now they're even darker, and now you can see the difference. So in conclusion, for liver metastases, acquire the portal venous phase at CT simulation to be able to see the difference between the liver metastases and the liver and be able to contour liver metastases the best. Hopefully this helps explain the best phases to use when contouring hepatocellular carcinoma, the hepatic arterial and the portal venous phase, and when trying to contour liver metastases, use the portal venous phase. Like I said, the contrast dynamics is a topic that you should become familiar with if you're going to be doing liver SBRT.
Physicists also need to familiarize themselves, or is that more directed to physicians? I
think physicians. Yeah. As a physician, you should know all aspects of the treatment that you're going to give. And, your team is willing to support you, but you need to give them clear instructions on what is it that you want, and then they'll follow your lead. It's probably going to be important on your on your simulation form, simulation request form, that you have some checkboxes or something that are asking about what phase scans you want the therapist to take, because you want to standardize things so that it becomes consistent and there's consistent practice amongst physicians. Okay, breath hold simulation with IV contrast, multi-phase IV contrast enhanced breath hold scans. So this is with no contrast. Notice how the liver looks like a gray blob, and it would be impossible to tell where the tumor is. Now, as we're going to different phases, we can see how different parts of the liver are lighting up. Okay, and I think that's the main point. This was cholangiocarcinoma, and I guess here it looks like it would probably have the sharpest delineation on this scan out of all of them. If I had to choose which one would I want to use, I would want to use this one. Okay. Now let's look at a different kind of liver cancer. We have liver metastases. Again, with no contrast, it's worthless. And we do need to get the right phase to see it well. Here it also looks like this phase is helpful. Is that 60 seconds? Okay, pancreatic tumor. Let's see. To me, I'm looking at these, saying which one would I want if I had to contour the tumor. Without contrast, this looks very hard. It's hard for me to tell what's the pancreas and what's tumor. In the early phase, now I can see the vessels, and I can see the gray that's not vessel, and I can see how this gray looks different than the pancreatic tail. So in the late phase, I'm seeing less of that contrast. It's finished circulating, and I don't think it's as helpful. So either this or this looks more helpful to me. Okay, breath hold simulation with IV contrast. So remember the graph we had with arterial, the parenchymal, and the portal venous? This is showing pictures in those different phases. He calls this a triphasic graph, and a good length. We'll get to that question. So when you have the right phase, basically you'll be able to contour better. You'll more accurately make sure you're not missing, and also make sure you're not drawing more than you need to, because it's going to make the treatment planning very hard. I'll share these slides so that you can review them afterwards. So let's take a look at the setup. We have a lot of things going on. Some of these we're familiar with. They have some immobilization devices, and some of these things may be sort of new. And every center is going to have their own different technology. I don't know exactly what everyone has, but in this case, I'll point out they have this thing called the RPM box, and they have this camera, a special kind of infrared camera. And the box and the camera are communicating. What's going to happen is, as the patient breathes, their abdomen is going to rise and it's going to fall. And that's one way to track motion. And this camera can help to sense how much it's rising and how much it's falling to tell what phase is the person. These look like virtual reality goggles. They're visual feedback goggles. And when the patient's looking inside it, they're going to see something which looks like a basic screen. It's going to look like they're playing a game, and they want the line of their breathing to be in a certain place so that it doesn't go too high and so it doesn't go too low. And they try to hold their breath in the right place. So this is for a breath hold. And this is what you might see on your treatment console. You can see how the patient's breathing is. And then here, this blue and red, this is your acceptable threshold. As long as the patient is holding their breath in between these lines, I'm good. The treatment beam is on. And then if they fall out of it, because they can't hold their breath forever, then the beam stops. They catch their breath, and then they hold their breath again. A patient may need to hold their breath like 20 times or more during treatment. So sometimes this is harder in older, frailer patients. Okay, the CT simulation. They have this contrast injector and the IV line connected to the patient. This contrast injector is specific. You give it its settings and you tell it when you want the timing to be in relation to the scans. Any questions? Okay, Salim has a nice comment. He personally uses a footrest, very important to avoid rotation at the hip level with huge impact on the diaphragm area. Yeah, I think that's great. Yeah, if you find that that's helpful and other centers can try it too, it seems like an easy win. Rotation at the hip can certainly be a problem. In some cases, we'll use a backlock bag to just keep the whole body still. We're just trying to be very careful and keep things from moving as much as possible. I will note that what is the wrong way to do the breath hold? Don't just eyeball the patient and tell them to hold their breath, and then while they're holding their breath, do the treatment. Like, no. You need a lot of devices. You need to have constant feedback. You need to be measuring how much is the breath hold. Everything has to be super precise for breath hold. Okay.
So
this is a cheat.
So as long as we are using the breathe hold technique, we don't need fiducials in such a concept.
You may still need fiducials to line up the patient. I myself am still learning what's the best time to use fiducials or not. I think sometimes, Soha, you're not sure if the breath hold is going to be successful. So sometimes
because those quality of patients have obstruction, bilirubin congestion, and so introducing such a fiducials will carry out a very high risk for infection and interrupting treatment in other way to have infection, and so as this is what I've been advised, because I'm stratifying my program now, so everybody is advising me whenever you can do it without, do it, because you don't want to carry out much risk for infection, particularly for those patients. What do you think?
Yeah, I think it's a great point. If infection is going to kill a patient, you don't want that to happen. So you definitely have to weigh the pros and cons. I will say, as you get more and more experience with the liver and pancreas SBRT, and you get very, very good at identifying near anatomic landmarks, it's a tricky skill. We're not taught this, but it's a skill that you can gain and acquire through exercise. You don't need fiducials as much as a beginner needs fiducials. And you'll get to the point where you can do it without fiducials confidently using near anatomic structures.
That might be true for contouring purposes and planning, but what about the IGRT aspect of it, of the machine? I feel like the fiducials can be a good surrogate, right, for therapists to use when lining up the patient, no?
Yeah, I mean, certainly, like we said, for CyberKnife, it's almost necessary. For Linac base, the main thing is you want to make sure you're lining up the patient correctly, and so there, I think, being very accurate. Okay, so sometimes you will contour structures that will help the therapist know what to line up to, and then the therapist will look at that specific structure and try to line up to that. So it's a whole team effort. You're totally right, Sarah. I think for the daily setup, you need to make it easy for your therapist to be able to do it.
Exactly. That's what I was thinking. I was thinking Linac based, not CyberKnife when I said that. Yeah.
Right.
You start with the spinal cord, and then you look at the contoured organs at risk, but then fiducials is the fine tuning, right?
Yeah. If you don't know how you're going to line up the patient, then certainly if you are a physician or if you're a physicist and you don't know how you would line up the patient, then certainly the therapists on your team are going to have the same difficulty. So this is just another reason why this is tricky, Soha. Okay.
How high is the risk of infection when placing fiducials? I know there's an procedure, but is it that high of a risk?
I think it totally depends on the patient. Yeah. Sorry, I don't know a percentage. Okay, so this is showing a couple different dose schemes. This is showing what the total dose is in each of these schemes. And then this is showing what is the tumor BED achieved with each of these doses. Here are some dose limits that show for conventional fractionation. for hypofractionation and for SBRT. These may be what is used for guidance at this institution. And you can see that they set the V35 gray less than 1 cc for the duodenum and the small bowel. They set a Dmax less than 40 gray, and it's similar for the stomach and the large bowel. So I'd say this is a good rule of thumb, and it's kind of easy to remember. It's the same for all of these structures. For the liver, in the conventional and hypofractionation set, we're considered mostly the mean dose. And in SBRT, we use this metric, the volume of liver that's getting 12 gray, and setting that as less to 50%. Here's a question. If someone has cirrhosis, they have poor liver function, and let's say they have hepatocellular carcinoma, can their liver still handle as much dose as a healthy liver? The answer is no. You actually have tighter dose constraints in patients with cirrhosis. For liver, usually we're okay with a liver, but especially if you're doing liver SBRT, now you have to start to think, okay, what is the dose the whole liver is getting? And the worst case scenario is you can cause something that's radiation-induced liver disease, RILD. You can read about that, but it is a fatal process. So actually, where I train our liver SBRT, we usually do 50 gray in 5 fractions. If it's a patient with cirrhosis, then we have to do less dose, and we do maybe 30 gray in 3 fractions every other day. Yeah, so I can message you personally for specific dose constraints. I don't remember off the top of my head, but I do know it is lower than a non-cirrhotic liver. Okay, treatment planning strategy. So let's look here. We see GTV. We see PTV. Why is there no ITV? Because this is breath hold. Okay. If this was a 4D CT scan, then we would have GTV, then ITV, as we watch the motion of the tumor, and then we would make a PTV. So here, I think he's explaining how the PTV, that his practice is most specific. If he's using SBRT, he's using a 3 millimeter PTV. What this is a specific dose around where the tumor is making contact with the vessel, because you want to make sure 100% that you are clearing the tumor around the vessel. And I guess if you watch any pancreas contouring SBRT videos or lectures, you'll see this TVI mentioned, and it is a volume that they recommend including in your planning target volume to make sure that you are getting all of the tumor around the vessel. It stands for tumor vessel interface. So this is just a picture of treatment planning for a typical liver hypofractionation. In this case, this was 15 fractions of 4.5 gray versus this liver treatment. This was 5 fractions of 12.5 gray. And notice how the dose fall off is steeper here compared to here. And then I guess we can't see how hot it is in the middle, but I would expect that it's going to be hotter in the middle compared to how hot it is in the hypofractionation. You can see that how broad this shoulder is sort of can tell you how hot is it in the middle. If it was a super steep shoulder, we would know that it's a pretty homogeneous, almost all of it is getting a certain dose, but not a lot is getting hot doses. Here, but it's spread out, so we know that there's lots of areas of higher dose in the prescription in the middle. Whereas here we have a sharper dose fall off, so we know it's a more homogeneous plan.
Would you please say it again, Ben?
Yeah. I mean, this is really just kind of a trick to be aware. But normally when we plan not doing SBRT, doing like 3D conformal or IMRT, we want to avoid lots of heterogeneity. We want to make it a pretty homogeneous plan without lots of big hotspots, right? When we look at our target dose volume histogram line, this red line, it's going to look like a very steep fall off. It's going to look like a very almost like a cliff. Okay. And this is saying that this is pretty homogeneous. Let's say I was prescribing to whatever this dose is. I guess in this case, they did 4.5 times 15, 67.5. Okay. So they prescribed a 67.5. We see there's probably around 90% coverage. And then beyond that, there's almost no dose that's getting 70 gray. So 70 gray is 103%. So everything is less than 5% hotspot. Okay.
Yeah.
Now,
okay.
Now look,
and there is no tail. Also, it's just steep.
Right. No tail.
Yeah. Okay. Yeah.
Whereas when you're doing SBRT plans, you are going to have a big tail, because in order to achieve this steeper dose fall off, sort of the top of the mountain needs to be here, if that makes sense. So here they're prescribing to 60 gray, and we can see that here. And then rather than having a very immediate stop to higher dose, where there are areas that are getting higher dose. Okay, so now can you hear me okay? Good. Okay, I wanted to show you guys to help answer some of your questions. Okay, so I guess we'll just give 30 more seconds. So it's 15 minutes. Good to see this group still here. So let's look at the simulation instructions that we use. So this is the kind of sheet we use at my center. And we can see this is an instruction specifically for liver SBRT. So every time we do liver SBRT, we're using this instruction sheet. And there are a couple things that we can check if we need to, like, does a patient need a translator or not? Does a patient have a pacemaker? Basic things like that. Then we get into instructions for the CT and talking about, are we going to use IV contrast? Which phases do we want? So in the case of liver metastases, we'll use the portal venous phase only, because this gives the best enhancement for liver metastases. For hepatocellular carcinoma, we'll do arterial and portal venous phase. So you can make specific instructions depending on what kind of liver SBRT you're treating. We don't really need to use oral contrast unless there is a specific reason. And then these are just talking about scan ranges that you can see, starting at 7 centimeters above the diaphragm, and the lower border could be 2 centimeters below the pelvic rim. Or if there's a specific thing that you want, you can type it in. Motion management. Can they do breath hold? Here we use the SDX. So if they can do it, then we check this box. And then we specify, do we want them to do inhale or exhale breath hold? Inhale is probably easier for the patient to do. It might be a little bit worse for liver and pancreas in terms of bringing the tumor closer to the OAR. Exhale, you can try to do, but if they can't tolerate it, then you might have to do inhale. Or you could just establish your standard practice where we only ever do inhale. Up to you. I will say that even here with 2 different GI doctors, they disagree. So clearly there's no clear one or right or wrong answer. If they can't do a breath hold, then we do a 4D CT scan. So this next for MRI, if they haven't gotten an MRI, they're certainly going to need an MRI. If they already have an MRI, you can bring that in. If your center has an MRI simulator, then this would be a great time to use MRI simulator. And then the scheduling. So is it just one tumor that you're treating? In which case we might do 5 fractions every other day. Are there 2 different tumors that you're treating? Do you want to treat them as separate courses? And if you do, which one do you want to treat first? Or are they 2 tumors, but you want to treat them on the same day? So there's going to be variations for you to consider, okay? Next, let's look at the planning instructions, okay? So I think this will answer your question. Let me know if this is helpful or if this is boring. So similarly, we have some stuff standard, who's the patient, what's their identifier. Okay, so for image-guided radiotherapy, are you using fiducial markers or not? And for each one, if you are using it, are you using breath hold or are you using free breathe? So there's going to be 4 situations, and you check which one applies to you. If you are doing alignment without markers, then you can choose your first priority is to try to avoid overlap with a specific organ at risk. Above all, I don't want to do damage to the patient. So I'm going to make that my top priority is avoiding PTV overlapping with a specific OAR or a certain isodose limit overlapping with the OAR. Maybe you want your 30 gray line to not overlap. So you would make a contour or export your 30 gray isodose line as a contour so that the therapist can see that and make sure that that is not overlapping with a specific OAR. And then secondly, you can tell them what to try to align things to. So unfortunately, not enough time to go into details here, but hopefully this can help you appreciate just some of the complexities to consider. Now let's get into the dose constraints. So before you saw some for MD Anderson, now this is for a different institution. I guess you could screenshot if you want this, take a picture. I want to highlight for liver. If it's a liver with cirrhosis, this one, or if it's a liver without cirrhosis. So if it's a liver without cirrhosis, our constraints are not as tight. If it's a liver with cirrhosis, here we have specific limits. Liver dose, MLD. A liver with cirrhosis being treated with 5 fractions. If we're doing, I'll explain this again. So in the setting of a liver without cirrhosis, these are going to be constraints that we use, okay? In the setting of a liver, any liver, these are the constraints we're going to use. Now, the constraints depend on what we're prescribing, okay? And as I said, if we're doing a liver with cirrhosis, we prescribe less because it cannot take as much. Now, where do you draw that threshold? It'll depend because there's varying degrees of cirrhosis. Do they have severe cirrhosis or do they have just like very, very mild Child-Pugh A cirrhosis? So use your judgment. There's no clear right answer. But someone with very bad cirrhosis, I probably would prescribe 30 gray in 10 fractions, or sorry, 30 gray in 3 fractions. And my mean liver dose is going to be limited to this 13.2 gray. On the other hand, if I'm treating a healthy liver, I'm doing 50 gray in 5 fractions, then my mean liver dose constraint is going to be 13. So this is just to help you see specific examples of what fractionation, what dose are you prescribing, and what mean liver dose constraint to use. Okay.
Ben, I don't know. I never been in this setup. My gut feeling is it's hard to start with 3 fraction in cirrhotic liver. I think 5 fraction will give you a margin of safety more than the 3 fraction in a conditional cirrhotic liver. If I'm the one who is designed, I will not go for tight fractionation in a context of diseased liver. What do you think?
Yeah, I think that's a good point. I think practice patterns will vary. Of course, I'm just saying obvious things, but someone who's very, very comfortable and does this SBRT all the time, they might be more comfortable doing 3 fractions. But I think you bring a good point. And if I was trying to be cautious, I would do maybe more fractions to spread out the dose so it's gentler. So I think you bring a great point, Soha, and I agree with you.